ACL tears are one of the most common sports-related injuries, accounting for over half of all knee injuries sustained in sport. Athletes who sustain an ACL injury can experience persistent knee instability, which places them at higher risk of other injuries, including meniscal tears, cartilage damage, and early knee arthritis. For these reasons, ACL reconstruction has been the go-to option for those looking to return to sport. Over the years, ACL reconstruction techniques have evolved, with patients being able to choose from several different types of ACL grafts. But not all graft types are created equal, and those undergoing ACL reconstruction surgery should understand the unique aspects of each, as selecting the wrong type of graft can potentially impact recovery and post-surgical outcomes. In this video, we will cover what you should know when it comes to choosing an ACL graft. There are two common types of grafts utilized during ACL reconstruction: allografts and autografts. Both ACL autografts and allografts are tendons used to replace the injured ligament. Allo, meaning other, are grafts made from harvesting the tissue of a cadaver. Auto, meaning self, are grafts made by harvesting the tissue from the individual receiving surgery. Let's start off by looking at autografts. Utilization of live tissue from the patient provides autografts with several key advantages and have made them a popular choice for ACL reconstruction. Some of the major advantages of these graft types include reduced risk of infection, lower immune response and chance of graft rejection, as well as more rapid graft healing rates when compared to allografts. There are several types of autografts that can be utilized and, depending on the individual's goals and sport requirements, have their own pros and cons. The most common type of autograft utilized in ACL reconstruction include the hamstring and bone-patella tendon bone grafts. Bone-patella tendon bone autografts have been historically considered the benchmark of graft utilized in ACL reconstructions. This is mostly because of its long-standing track record and widespread use around the country, including in professional sports. During this procedure, the surgeon takes a portion of the central aspect of the patella tendon, as well as parts of the bones at each corresponding end. These bony plugs allow for a more secure fixation and faster rate of healing when compared to grafts utilizing tendon alone. This is because bone heals faster and stronger compared to soft tissue healing, with bone grafts healing within 6 weeks, while soft tissue grafts taking about 8 to 12 weeks to fully incorporate into the surrounding tissue. Although bone-patella tendon bone has become the most common graft source for ACL reconstruction in the US, there are some notable complications associated with this graft type, the most common of which is anterior knee pain. Studies show an incidence rate of anterior knee pain in up to 30% of patients, with pain being most prevalent in those who participate in sports or jobs that require repetitive kneeling. Quadriceps weakness is another common issue, affecting as many as 15 to 20% of patients and is seen in individuals as many as 2 years after surgery. Some studies have shown a higher incidence rate of post-surgical arthritis with this procedure as well, but this was more of an observational finding and it did not necessarily result in increased pain or impact function. Due to the need to harvest the bone plugs, bone-patella tendon bone autografts are not recommended in those who are not skeletally mature, as the methods utilized during this procedure can increase the risk of harming the growth plates. During a hamstring autograft ACL reconstruction, the surgeon makes a small incision along the inside part of the knee where the ends of the hamstring are harvested to make the graft. This graft type has been shown to result in lower rates of post-operative arthritis and does not result in the same quadriceps weakness that is commonly experienced in those who receive bone-patella tendon bone grafts. There is also less anterior knee pain reported, especially during kneeling and with strenuous activities. Because parts of the hamstring are used to form the graft, the primary disadvantage of this graft type is hamstring weakness that can persist after surgery. This may negatively impact performance in those who participate in sports that put high demands on the hamstring muscles, although this can be overcome with a comprehensive strength program. Healing is also slower compared to bone-patella tendon bone grafts due to the fact that this is a soft tissue graft which takes more time to incorporate into the surrounding tissue. Let's now look at the other graft type, allografts. Common allografts include the Achilles or patella tendon, and less commonly the tibialis anterior and tibialis posterior. Because allografts utilize tissue from a cadaver, there is no need to harvest any tissue from the individual receiving surgery. This results in significantly less post-surgical pain and minimizes the losses in muscle strength that you typically see with autografts. In addition, allografts have been shown to have lower incidences of post-operative knee stiffness and shorter operative times. However, there are serious disadvantages to this graft type. This graft has been shown to have relatively high re-rupture rates when compared to autografts. This is attributed partly to the potential loss of structural and mechanical integrity of the graft that occurs during the sterilization process. Another reason for the higher re-rupture rates is the slower healing times of this graft that makes it susceptible to failure. Re-rupture rates with allografts are most prevalent in the younger population, being shown to be 3 to 5 times greater than autografts, and appear to be the most prevalent in individuals under the age of 30 years old. A study looked specifically at individuals under the age of 18 years old who received an ACL reconstruction. The authors found that those that received an allograft had a failure rate of 15 times greater than that of the autograft group. All failures occurred within the first year after reconstruction. There appears to be no difference in re-rupture rates in individuals in their mid-30s or older. Due to the higher risk of re-rupture, allografts are typically reserved for older patients, those who are undergoing revision surgery, or those who are not looking to return to sport or who have lower work demands. So how do these grafts compare when it comes to post-surgical rehabilitation? Well, a study investigated the rate in which individuals who received ACL reconstruction achieved specific rehabilitation milestones. These milestones include strength, functional performance, as well as subjective questionnaires on perceived ability levels. The study found that those who received bone-patella tendon bone grafts took 1.5 months longer than the hamstring tendon group and 2.5 months longer than the allograft group to achieve the same clinical milestones. The delay in the bone-patella tendon bone graft group was associated with slower recovery of knee range of motion, prolonged swelling, and time needed to regain quadriceps strength. The bone-patella tendon bone graft group did not achieve the criteria established to return to sport until over 10 months after surgery. The allograft and hamstring tendon groups achieved this criteria 6.5 and 7.5 months post-surgery, respectively. Now, this delay in recovery in the bone-patella bone group may seem like a major drawback, but physical function is just a piece of the recovery process and does not take into consideration the healing of the graft itself, which is a major factor when determining readiness to return to sport. It is estimated that up to a quarter of athletes experience a second ACL injury following return to sport. These injuries are most common when return to sport falls within 9 months after reconstruction, no matter their physical performance measures. So even though those who receive a bone-patella tendon bone graft may progress at a slower rate, they may actually be at a reduced risk of re-injury compared to those who receive an allograft or a hamstring tendon graft, as they are more likely to return to sport later. So what graft is best? Well, when it comes down to it, medium and long-term outcomes of either of these graft types are very good. The majority of studies show a very high rate of patient satisfaction with ACL reconstruction, regardless of the type of graft used. Both autografts and allografts have shown satisfaction rates of over 90%, and there is no apparent difference in knee stability, strength, or functional knee scores in the long term. What it ultimately comes down to is the individual's goals and sport or work demands. A bone-patella tendon bone graft may be best for a track and field or football player who cannot lose hamstring strength for speed, while hamstring graft may be best for those who kneel regularly, such as a wrestler or a mechanic. Overall, the evidence for bone-patella tendon bone and hamstring autografts show equivalent rates of returning to pre-injury level of activity, excellent functional outcomes, and low risk for long-term complications. An allograft may be a good option for an older person with less physical demands, as there is notably less post-surgical pain and no loss in muscle strength. However, this graft choice should be avoided when possible in younger, more physically active patients because of the higher rate of failure. Well, I hope you enjoyed this episode of Physio Show. Make sure you like and subscribe to the channel to receive more physical therapy related content.